Good day. I would like to begin by thanking the organizing committee for this wonderful opportunity. I am presenting a case on craniofacial fibrous dysplasia. The term fibrous dysplasia was first introduced by Lichtenstein in 1938. It is a benign fibro-osseous bone disease in which normal bone marrow is replaced by an abnormal proliferation of new fibrous connective tissue. The three subtypes of fibrous dysplasia are monostotic, polyostotic, and craniofacial. Craniofacial is used to describe lesions which are confined to contiguous bones of the craniofacial skeleton. Cosmetic recontouring is the treatment of choice. However, more aggressive treatments are indicated if the lesion is large. We are trying to introduce a recent treatment modality in managing these cases where we use stereolithographic models, which are surgical guides that are useful in which mirror images of the normal side is created so that a template could be made and the amount of reduction could be planned accurately. It helps in reducing operating time while increasing the accuracy of reproduction of the virtual surgical plan. A 20-year-old male patient reported to the department with a chief complaint of swelling in the right lateral part of forehead, as we can see in the image, since 8 years. He gives a history of being hit by a stone on the affected region 8 years back, following which he noticed a small swelling over the region that was initially the size of a peanut and that gradually increased to the present size 2 years back and having remained of the same size since back then. He has no any associated symptoms such as headache, pain, dizziness, convulsions, or visual disturbances. On facial examination, a solitary bony swelling was noted on the lateral one-third of the right supraorbital region that measured approximately 5 into 5 into 5 in maximum dimensions. The lesion was roughly oval in shape with the color of the lesion and its surrounding area appear to be same as that of the adjacent normal skin color. On palpation, it is bony hard in consistency, non-tender, immobile with well-defined margins and not having any localized rise in temperature. 3D CT phase revealed an expansile bony lesion measuring 4 into 4.8 into 4.8 centimeter that was involving the right orbital portion of the frontal bone and that which was inferiorly extending to involve the upper part of the lateral margin of the right orbit and the roof of the right orbit and that which was posteriorly extending up to the orbital apex that caused a reduction in the intraorbital space volume. The lesion showed an expansion of the outer and inner cortices with a ground glass density matrix within and with the margins of the lesion showing a narrow zone of transition. The lesion was provisionally diagnosed as craniofacial fibrous dysplasia and was treated by surgical recontouring under general anesthesia. A bicoronal incision was given and the flap was raised to expose the bony lesion. You can see in the first image where the bicoronal flap was raised to expose the lesion, and over the lesion, a checkerboard pattern was created using micromotor and drills. And each square was removed using chisel and mallet. Each square, as seen in the first image, was removed using chisel and mallet. The template that was made on mirror imaged stereolithographic model was adapted to the deceased side at regular intervals as a guide for proper bone reduction and for checking bilateral symmetry. In the second image, you can see the stereolithographic model, the stent that was made with the stereolithographic model, which was adapted onto the deceased side and was checked for reduction. Trimming of bone was done with diamond burr until the template was completely adapted to the bone. A surgical drain was placed and layer by layer closure was done using absorbable suture and the outer layer using 3,0-ethylene suture. Post-operative follow-up was done for 6 months, where satisfactory healing was noted with no evidence of any recurrence. On histopathological examination, decalcified sections showed broad, discrete, irregularly shaped trabeculae of cellular osteoid and mature lamella bone in loosely arranged, relatively cellular fibrous tissue with few areas of trabeculae showing osteoblastic rimming along with peritrabecular clefting. Literature review. Fibrous dysplasias are benign tumors where normal bone marrow is replaced by abnormal fibrous connective tissue. They cause aesthetic problems, particularly when facial skeleton is involved. Usually they are asymptomatic and slow growing. Fibrous dysplasia usually appears in the first or second decade. It may cause facial deformity and asymmetry, visual alteration, auditory disability, nasal congestion and or obstruction, pain, paresthesia or malocclusion depending on the type of fibrous dysplasia and its location. Rarely they cause functional impairments when the growth impinges on vital structures. Recontouring is the treatment of choice. However, to accurately estimate the amount of reduction required is challenging. Stereolithographic models, which are 3D printed models based on computed tomography scan, have gained popularity in the recent times for management of craniofacial deformities. The treatment should aim at preventing functional complications while improving regional aesthetics. Surgical treatment ranges from curettage, bone remodeling, contouring to more radical approaches like total resection of involved bone with immediate reconstruction. Aggressive surgical techniques are preferred as it allows for complete removal of lesion. So the treatment was based on the zones, based on classification of skulls into 4 zones and the relative reconstruction importance of each zone. Zone 1 includes frontal, orbital, nasal, ethmoid, zygoma, and upper maxilla. This area is most conspicuous facial region and thus lesions in this region require complete excision and reconstruction. Zone 2 includes parietal, part of occipital area, and the lateral cranial base and temporal zone. This zone being hair covered allows for option of conservative or radical resection. Zone 3 includes central cranial base, petrous, mastoid, pterygoid, and sphenoid bones. This zone is difficult and most times dangerous to manage. Thus, it is usually treated non-operatively in an asymptomatic patient. Zone 4 is further subdivided in 4A and 4B. The former includes maxillary alveolar bone, while the latter consists of mandible. Because of its teeth-bearing feature, conservative excision and recontouring is recommended. This approach for the treatment of craniomaxillofacial fibrous dysplasia was initially given by Chen and Nordhoff and later modified by Ricalde and Housewell. 3D models, also called as stereolithographs, have been utilized for different purposes since their introduction by Charles Hull in 1982. In the Department of Craniomaxillofacial Surgery, 3D printing have been utilized for different purposes since its introduction, like distraction osteogenesis, orthognathic procedure, management of craniomaxillofacial deformities, TMJ disorders, etc. 3D printing enables the surgeons to visualize the procedure and forecast the challenges before the actual beginning of procedure itself. This technology helps in producing models with minimal or negligible discrepancy from the original and accurate structural details rapidly to allow better postoperative outcome and decreased duration of surgery. Acrylic, epoxy resin, or 3-dimensional printed models are most commonly used in maxillofacial surgery. SLA models are fabricated using specialized software that can link information gathered from a computed tomography scan and can print it to a resin replica. The model is fabricated in such a way that each slice of an axial image on CT scan corresponds to a series of layers in the model. Management of craniofacial FD poses a challenge to surgeon owing to its functional and aesthetic implication. SLA models printed using 3D CT scan can help both in accurate treatment planning as well as aid in creating a surgical stent to maximize outcomes. Accurate recontouring while maintaining aesthetic harmony of face as a challenge was easily dealt using this technology. These are my references. Thank you once again for everybody who have participated and for the organizing committee. Have a nice day.